I'd like to introduce our next speaker, Ravi Kavasery. Ravi serves as the Medical Director of Quality and Population Health for Ultimate Health Services. His talk, entitled How the Largest Federally Qualified Health Center in America Navigated COVID to Address Health Equity. Ravi?
Thanks, Evan, and thank you, Asaf, for the opportunity to present today. Good afternoon, everybody. As this group is well aware, communities of color, particularly Black individuals and Latinos, are bearing the brunt of the COVID-19 pandemic. And the reasons for this are well known. They're the result of systemic racism and inequities across our healthcare delivery system. Next slide, please. So our organization, Ultimate Health Services, is located at the epicenter of the COVID-19 pandemic in California. We serve the communities of East Los Angeles predominantly, which are largely Latino, poor, and underserved. Many of our patients are low-income essential workers. They're more likely to live in crowded housing and unable to self-isolate or shelter in place. And they're less likely to have adequate access to basic legal protections, including paid sick leave. So when the COVID-19 pandemic hit, as leaders of Ultimate, we were faced with a difficult challenge that's been faced by all of our community health delivery system colleagues. How are we going to tackle COVID-19 in our communities, which are testing deserts, but are bearing the burden of the COVID pandemic? And how would we do this without any guarantee of financial support or reimbursement? Well, the care is changing, but our responsibility for caring does not. Next slide, please. We prioritized 3 key changes to our care delivery system. First, we looked for a partner to help us scale access to COVID testing in our communities because we knew they were going to be the ones hardest hit. We partnered with the Los Angeles and Orange County Departments of Public Health for access to testing kits. And as of last week, Ultimate performed 42,000 tests in the communities that we serve. This includes not just for our patients, but also for community members. This constitutes 11% of all testing that's been done in Los Angeles and Orange County to date. And as we anticipated, our testing positivity rate in the communities that we serve have consistently been higher than the rest of Los Angeles and Orange County. Second, we pivoted our care delivery system to telehealth. Prior to COVID, as folks are aware, community health centers really are bottlenecked by face-to-face visits. 100% of our physician visits were face-to-face. 50% of our care is now telehealth. We had a drop in system access and capacity in March as we were standing up this infrastructure, but since April, we've maintained health system access and visits to pre-COVID levels. And we're now transitioning from phone-based visits to video visits. Third, we proactively outreach to those patients who need us most, including our diabetic patients, frail elders, and children with complex conditions. At Ultimate, we have over 11,000 uncontrolled diabetic patients. And in the months of March, April, and May, 58% of our uncontrolled diabetics had a touch point, a visit with a physician, either by phone or in person. Likewise, today, in a partnership with the Children's Hospital of Los Angeles, we're currently scaling drive-through immunization clinics for all of our pediatric patients. Next slide, please. So what reflections would we like to share with this group? Like all of you, we're still processing what we're learning. But a key learning for us has been that the conversation needs to move beyond the potential of telehealth. What we're really talking about is moving care delivery beyond brick and mortar care and meeting the patient where they are. 2 specific examples for you. First, in our communities, the challenge is an absence of broadband communication. So as much as we would like to stand up video visits for our patients, we need to make sure that they have access to broadband first so that they don't eat up all their cell phone plan data in order to speak with their physicians and their care teams. Second, many telehealth platforms for patient remote monitoring are not language concordant. Language concordant is still seen as a nice to have for a lot of these remote patient monitoring applications and not a must have. Health systems of the future are no longer the future. We have an opportunity to close the equity gap, and unless we rapidly scale and invest in digital health for underserved communities and ensure that they're culturally and linguistically appropriate, we risk leaving our communities even further behind. Next slide. And perhaps the most important reflection for us is expressing gratitude and appreciation as the key to resilience. We're in times that call for resilient leadership, and with that, I would like to close these final 2 slides thanking my operational partner and friend, Paula Jameson, who teaches me about leadership every day. We also thank our extraordinary leadership team and Ultimate's clinic teams who are our heroes on the front line. Thank you.
Ravi, thank you so much for that. Can I quote you? I really enjoyed what you said. The care has changed, but caring has not, or our responsibility for caring has not. I love that. Care has changed, caring has not. Can you mention, moving to telehealth so quickly, I'm sure was really challenging. What type of cooperation were you getting from the payers? And did you have to do anything to bring them on board?
Yeah, that's a great question. Thanks, Evan. We work with 13 health plans and have a mix of patients in lots of different populations. I think as Asaf and you alluded to in the beginning, there's just a recognition here that this is not business as usual, and we have to build to the future we want to stand in. So we are building towards a world where telehealth is the future and not worrying about whether or not it will stay. Our health plans today, CMS has recently said that starting next year, telephonic care will not be reimbursed. So instead of us walking back to face-to-face visits, we're moving forward into video visits. And so that's where we're moving our energy today. Similarly, payers have been trying to give us increased P4P dollars as a way to sort of fund other care to take place. So a few of our health plans, our larger health plans here in California today, have doubled the pay-for-performance incentive dollars as a way to give us additional funding streams. By no means are these going to be sufficient, but they give us a path to align our financial revenue streams to the supporting infrastructure and technology infrastructure we're trying to build. Great question.
Thank you so much, Ravi.